Good afternoon, everyone. I'm Dr. Scott Martin. This is the Institute of Regenerative Education, and happy Monday. Now, I just got back from Mexico. It was crazy, much more work than I had planned on doing, and I was going to drop this video while I was there, but I got pretty aggressively distracted by sorting some of our IRB issues. We have flies here in the house for whatever reason. I have no idea. Go. Okay. It must be another one of my haters flying around trying to interrupt a video. Good morning. Now, the reason we created the Institute of Regenerative Education is that knowledge changes, protocols change. And we have tried to be very, very nimble at the Institute. And so when you see protocols for anything, I want you to understand scope. When we create a protocol for anything, we are trying to assimilate best practices from providers all across the United States. Now, we have thousands of providers in the Institute of Regenerative Education, and we have almost 10,000 providers that are using allogenic biologics. And in using those biologics, many people have opinions, some strong, some stronger, much stronger, about how they should be used. But we create protocols on one simple paradigm. The outcome needs to be actionable. We need to see that it works. Number two, you need to be able to duplicate that outcome in any patient that walks through the door. And number three, you should be able to reproduce the same outcome in the same patient from first to second to third application, right? You can't do that with something like PRP. It's impossible. If I draw blood on myself today, the composition of my blood will be different based on my hydration, my nutritional status. It'll be different based on the supplements or drugs that I'm taking. It'll be different based on the time of day, right? And based on how much volume I get, single spun, double spun, leukocyte rich, leukocyte poor. That's why there has been no standardization with autologous biologics. And one of the reasons it's been so difficult to create actionable, duplicable, reproducible outcomes using those products. Allogenics is different, right? We are using dose-specific products, and so we get better results. But techniques can enhance the quality of results. And so we are updating our scalp restoration protocols, and I'm going to go through why. Now, if I take a standard scalp, right? Let's just say that we've got ears, got nose, eyes, all right? And this gentleman wears his hair parted like this, okay? Our typical scalp protocol assumes the following. All right. Number one, that we have inflammation. That inflammation is typically due to the peripheral conversion of testosterone to dihydrotestosterone. Inflammation does a number of things. Number one, it causes vasoconstriction of peripheral blood vessels. If I get vasoconstriction of peripheral blood vessels in the scalp, I don't get any blood flow to my hair follicles. If I'm not getting blood flow to my hair follicles, my hair falls out. Number two, that inflammation is breaking down the collagen around the hair bulb. And that collagen is type 1 and type 3 collagen. So down 2.5 millimeters in the scalp, you have a hair bulb. That hair bulb has a shaft of hair in it, collagen around it, and that collagen around it is type 1 and type 3. Well, we know that inflammation denatures collagen. When you have inflammation, when you have elevations in IL-1 beta, elevations in TNF-alpha, elevations in IL-6, those will down-regulate the proteins that would create collagen, SOX9A, aggrecan, COL2A1. Now, most of our patients that are losing hair are losing it for a number of reasons. GLP-1s is a very common reason. Stress, thyroid issues, hormonal imbalances, menopause, perimenopause, stress. All of these issues are causing people to lose hair. How do we combat this? Well, if we want to look at the two primary issues with scalp and hair loss, we need to, number one, counteract the inflammation so that we don't get vasoconstriction, and we also need to replace some of that collagen. Many of you have seen this, right? Where we have function at the top, we have inflammation here, and we have collagen differentiation here. Well, function can mean function of the hair follicle, just like it can mean function of my knee joint. And we need to down-regulate inflammation and up-regulate collagen differentiation if we want hair to move from shedding to resting to growth. I'm going to repeat that. Anyone who is losing hair, their hair does not suddenly go from shedding to growth. It needs to go from shedding to resting to growth. So you need to get all of those hair follicles from a shedding phase into a resting phase. And then they're going to spend a period of time in the resting phase before they move up to a growth phase. I do joke with folks and say, look, if you're in hell and you're trying to get to heaven, you're going to spend a long time in purgatory before that happens. So how do we do this best? Now, if we look at down regulation of inflammation, well, that would be very easy, right? We would use something like an exosome. Exosomes, we know, systemically down regulate inflammation. They down regulate IL-1 beta. They down regulate TNF-alpha. They down regulate IL-6. They up-regulate IL-10, they up-regulate ARG1. The biggest issue is that exosomes are anabolic. They're not catabolic, and they're not going to smack your blood sugar. So exosomes is a great idea. Well, but we also need to enhance collagen differentiation. We do have collagen-based growth factors in exosomes, but robust enough to mitigate the loss of collagen from something like pretty aggressive peripheral conversion of dihydrotestosterone? In my opinion, no. And so we tend to add a little bit of Wharton's jelly, which has primarily type 1 collagen, type 3 collagen, and hyaluronic acid. I also like to use GHKCU, free radical scavenging, balancing in the environment and promotion of all of those collagen-based growth factors so that we stabilize the environment and the body repairs itself at a cellular level in a bit better format. Now, when our first scalp restoration protocols came out, many of them were based on a nice paper that was published, and we'll put that paper and some of the other ones in this lecture. But there was a nice paper that looked at topical minoxidil. And if you microneedled before the application of minoxidil, it improved the efficacy of the minoxidil. And in some reports, over 20%. Well, many of our providers took that information and they applied it to scalp restoration as a whole. Now, all of our protocols are typically microneedle based. And because they're microneedle based, we are typically microneedling at 0.25 millimeters. We're using something like a doctor pen, so it's affordable because the microneedle tips for a doctor pen are about $3. I talked to a provider not 30 minutes ago who's using an RF microneedle device. His microneedle replacement tips are over $110. I don't know how you make any money doing that, right? I mean, your fixed cost for those disposable microneedle tips are more than skin pen. Skin pen's $86 and that's ridiculously expensive. $110 for a microneedle tip is brutally expensive and aggressively cuts into your net profit per procedure. We'll talk about that in a second. The way we are changing our protocol is as follows. And the reason I'm shooting a video is because you'll see the protocols change in the IORE. Now, typically, what we would do is first, number one, topical witch hazel. Prep the scalp and clean it, right? Never isopropyl alcohol. It will dry out the scalp. 2, we're putting 3 here. We would apply the biologic. And then we would microneedle, right? At 0.25 millimeters with either a 36 pin or a nano tip. Nano we typically used for men because men tend to pass out, right? But you'll notice a new paradigm. This new paradigm I've used in my own practice, I've used on myself, I've used on my wife. She does not like it because it's uncomfortable, but it is proving more efficacious. And it is the addition of a microneedle roller. We had a provider who read all the articles that I sent him. Many of you do, some of you don't. But in reading all those articles, he thought to himself, hey, look, if by pre-micro rolling an area enhances the effect of minoxidil, would it not also enhance the effect of the biologic? And so he added a step where he would cleanse the scalp, take a disposable microneedle roller, disposable meaning you're throwing this out after each use, just like the microneedle tip. These you can buy on Amazon for $5. You can buy them on Alibaba for 40 cents. And roll the area of application first, opening the channels. Then apply the biologic topically, then stamp with your microneedle pen the area of application. And so this new step we're going to put in blue, which is micro roll, R-O-L-L, the region. Now we do this, what are we going to call this? We do this step by step. Meaning, I'm not microneedle rolling the whole scalp. I'm taking a wide tooth comb, I'm parting the hair, and I'm creating this lovely part. Once I create this lovely part, and I've cleansed the scalp, then I will just roll the stripe where I can see exposed scalp, right? I'm not cranking it on the head. I'm just gently rolling it along the scalp, all right, to open up the stratum corneum. Then I'm applying biologic along the area of exposed scalp, and then I'm microneedling at 0.25 millimeters with a 36 pin or a nano, just that region. Then I will take a wide tooth comb. I will pull all the hair back, and I will part the hair, let's say, closer to the middle. And we end up doing the same thing. We've already cleaned the entire scalp. We don't have to do that again. All right? We will use our microneedle roller. We will roller that area again, and then apply our biologic, and then stamp the area. Once we've finished with that region, we will take a wide tooth comb and we will part again. Moving from one side to the other, right? And again, the scalp is already clean, so we're going to use our microneedle roller the area. After we've rolled the area, we will apply biologic from the front to the crown, and then we will microneedle stamp the region. This process has proven to be really, really, really actionable. Folks are getting very good results. And it makes sense. Our rate limiting step in getting biologic to the hair follicle, which is 2.5 millimeters down, is actually getting through the stratum corneum. Now, we've used a microneedle pen to get through the stratum corneum, but how much are we getting through, right? This pre-opens the stratum corneum so that when you apply biologic, it's already starting to seep through, and then we microneedle over, all right? This process, I think, is going to elevate everyone's application paradigm, and I think it's going to get everyone better results, all right? Now, you may come up with a better process. You may come up with just a better way of doing that, and if you do, awesome. Send it to me, and just like anything else, I'll vet it on my own patients, and if it proves better than this protocol, we'll update this protocol as well. Because in the Institute, our job is to innovate. Now, when we're talking about biologics, all right, what do I use? I use two tiers. I use a low tier, and we're going to put low tier up here, and we're going to put high tier down here. My low tier, I am using Renew XO plus GHK CU plus Nano Jelly. It's low tier because it's low cost, right? My Renew XO is 10 billion exosomes. My Nano Jelly is 70 milligrams of Wharton's jelly. I've got $100 in cost plus around 20 plus around 150, all right? In total, I'm still under 300 bucks. Fabulous. What is my high tier? My high tier, Nano EX plus GHKCU plus I use Nano DPM. 50 billion exosomes, 100 milligrams of Wharton's jelly. I've got 250 plus 250 plus 20, right? So I'm in around $500. Now, if you are buying these products in lots of 10, you're at $200 for your Nano X, you're at $200 for your Nano DPM, right? And so if my cost here is around $400, what am I going to charge? In my office, I charge $1,500, and I give a $300 discount for them to be part of the observational registry. Because even in scalp restoration procedures, I'm still tracking outcomes. I'm still enrolling these people in the observational registry, and I'm looking at adverse events, meaning I'm looking at self-limited adverse events, serious adverse events. So when I'm tracking myself, right, I'm putting Platinum Biologics as the product manufacturer, products, I'll add these products, right? Nano X, Nano DPM, route of application, microneedle, right? Number of procedures, I don't know, call it, 70 or 100, right? Self-limited adverse events, God willing, 0. Serious adverse events, God willing, 0. And I tabulate those every month, right? And that's what I do in my own practice. Now, do I also collect more data than this? Yes. I actually have patients who are tracking using the aesthetics form, right? Where they're looking at those 15 questions at 0, 3, and 6 months, all right? And they're answering those 15 questions at 0, 3, and 6 months, all right? All of those forms will be available to all of you on the observational dashboard where you actually report your outcomes. So on the HL7 secure database, where you would push your safety and efficacy paradigms on an every 6-month basis, if you want to track patient-reported outcomes, you can do that as well. That's a lecture for a different time, and I'll do that later in the week, where we go specifically through what's going on with the observational registry. But this is what I do in my office, right? So remember, we're doing 4 applications 4 weeks apart. I tell patients to expect nothing for 90 days. And in expecting nothing for 90 days, right, they're patient with me. Now, do I use any supplements on top of this? All of my patients, I have them on either alpha lipoic acid or nitric oxide for vasodilation. I have them all use topical minoxidil 3 times a week. Not every day, because none of my patients would stick to it every day. So now what I have them do is I have them buy one of these off Amazon, or I'll send them home with one. And they roller and then apply their minoxidil every couple days, right? If they do it 2-3 times a week, I'm ecstatic. It's much easier for patients to be more compliant Monday, Wednesday, Friday, where they'll probably do it Monday and Friday, than telling them to do it every day, in which case they won't do it at all. And that's just been my experience, right? I do put patients on vitamin D3, which does help with scalp restoration, and biotin hair and nails. This is about as easy as it gets. Far easier than injecting. Note, there is no topical with this. There's no topical lidocaine, no topical BLT, because lidocaine and BLT will denature your biologic. So we don't use it at all. All right? But to review the protocol again, topical witch hazel to clean. We've parted the hair, we've exposed scalp. We will use a roller, a disposable microneedle roller. After you've used this for the patient, you throw it out. You can give it to the patient to take home if you want, but I throw it out and usually give them another one to take home. Roller the area that you're going to apply the biologic to, open the stratum corneum, apply your biologic from the front to the crown, and then microneedle by stamping from the front all the way to the back. This is the new nuance for our Scalp Savvy microneedle protocol. Again, I'm Dr. Martin. Everyone, have a very blessed day.